it's a pleasure for me to introduce Michael Curran from our Kentucky Department of Public Health, and essentially that is going to address one topic that, again, this is one of these topics that cross all areas, because it's one of the challenges that we've been all facing with the development of multi-resistant fungi, and specifically some multi-resistant Candida that Michael is going to give us an overview of what happened with Candida auris here in Kentucky. Michael, thank you very much, and the floor is yours.
Okay, so yet again, thank you very much. I do appreciate this opportunity to kind of talk with the folks that are available here for this Grand Rounds. This is an opportunity I was actually looking forward to doing for quite some time, ever since Ruth basically had addressed the possibility of this. And so, as Dr. Ramirez had alluded to, I'm going to talk to you actually about two things. The primary one is basically Candida auris within the state of Kentucky over the last 2 years. And I also want to talk to folks about the importance of interfacility communication as far as in regards to any infection control efforts and the importance of it. Just to give you a quick little idea of what we're going to be covering here. Giving you a real quick background on Candida auris period, and then the presence in Kentucky. Also going to take a look at basically case counts by month in the state between 2021 and 2022. And then we're also going to break that down into the specific demographics of like the individuals that have been identified with this particular and where it's been located, et cetera. We'll go over real briefly some response activities as far as what's been conducted basically at the local level and also through our state offices and coordinated with the antibiotic resistance lab network, regional lab up in Madison, Wisconsin that we use. And then two major things basically covering screening recommendations. So as you may have heard this along the way somewhere in some conversation that Dr. Carrico or Dr. Ramirez has basically covered with you. Early identification allows for you to implement transmission-based precautions early so that you can halt or completely prevent any kind of horizontal transmission of any pathogen of concern within your facilities. So want to cover that real briefly with you. As I had alluded to, we're going to talk about interfacility communications. And not only that, basically give an example of a coordinated response to the communication. It's not just the form, but basically what do we do with the form once we basically implement that into practice. So as I alluded, background, Candida auris, and I'll go through this real briefly and highlight a couple of important parts. It is an emerging pathogenic yeast. Invasive infections have been associated with approximately 30 to 60% mortality among hospitalized patients. Back in 2019, with the release of the CDC AR threats report, Candida auris was listed as an urgent public health threat for the following reasons. The biggest being the potential of Candida auris to show multi-drug resistance. You can see the numbers here as far as like what's been showing up across the country. What I can tell you is for every identified case of Candida auris that has had antifungal testing conducted on it, from what we've been notified, every single one of them have shown resistance to at least one classification of antifungal. We have had several instances where there have been two classes of antifungals that have shown resistance, but we have not, knock on wood, have seen any cases where all three classes have demonstrated some resistance to antifungals. That's the good news. In addition to the potential for multi-drug resistance, it also has the ability to spread horizontally within healthcare settings. The biggest thing is that asymptomatic colonization with C. auris is possible, and that's the biggest issue where communication really comes in helpful. And then the final part, which is the reason why basically the CDC listed as an urgent threat, we've had rapid appearance in many parts of the United States, not just in one particular region. It is now pretty much across the entire country. As I had mentioned, early detection and communication, they are absolutely essential. If you take a look at, and I'm going to cover this a little bit more, the earlier cases that we had back in 2021, we had the index cases in the different regions where they popped up within the state. There was travel history and contact with healthcare facilities outside of the state of Kentucky. So when you're obtaining your initial medical history of these patients and trying to get an idea of what these patients have, make sure you obtain a really detailed medical and travel history, including contact with healthcare facilities. In addition, make sure that you have closed loop communication with units and other healthcare facilities. That'll basically close some gaps along the way when basically transferring facilities, not only between facilities, but between units. It's very, very important. The very first case in Kentucky was back in April of 2021. As you can see here listed below, many areas of the state have seen cases. Most recent addition to this list here was Jackson Purchase this year, but the other 4 regions all had cases not only, excuse me, I keep saying this year, I'm already forgetting we're in 2023, but I think you guys know where I'm going with this. But in 2022, we had the recent addition of cases out in Jackson Purchase. Here's a quick little breakdown of the cases by month within 2021. We had an initial burst of identified cases within the springtime of 2021, a little bit of a lull, and then we had a bit of, I guess you could almost call it like a surge of identified cases back in August and September. Most of that activity was surrounding aggressive measures, basically through screening. Like I said, coordinating not only through us at the HAI program, but also through our partners with the AR Lab Network regional lab up in Madison, Wisconsin. As you can tell, cases dramatically fell off after that, with just 2 cases identified in November and December combined. Both of those basically, if I'm not mistaken, the clinical case in December was in a case that was already previously identified, or at least well known beforehand. That was the good news. Moving to 2022, things have been a little bit different. We had a lot of quiet time going on in there in the beginning part of the year, and then we had a lot of cases smack dab in the middle of the year. Yet again, as I alluded to, a lot of this initial identified cases were there were issues and challenges as far as communication between sending facility and receiving facility. There also were situations where incomplete history as far as contact with healthcare facilities was basically demonstrated. But yet again, like I said, cases kind of like turned down a little bit towards the very, very end of the year. Most of that is basically, like I said, we were very aggressive as far as like if there was any sort of hint that there might have been a sizable gap in any kind of infection control, we just went ahead and basically ordered some point prevalency survey testing to be conducted at the facility to try and identify any possible transmission within the building. Now, who are these folks that basically were identified with this? We had 107 unique patients, basically between both 2021 and 2022. Their ages, as you can see on here, basically spread from as young as 21 years old to as old as 94 years old. We had slightly more, actually about 2/3 of the patient-ish were male, the rest were females. Unfortunately, we had 14 deaths that were associated with identified cases within the state of Kentucky. I do want to point out that those 14 deaths were not necessarily as a direct result of the Candida auris infections or colonization. It's just that they were associated with previous identified cases. So just want to be clear with that. Then if you take a look over here as far as the settings, the one thing I did want to point out is the majority of our cases were located at LTACs spread throughout the state, not in just one particular region. We will circle back to that, but the one thing I did want to point out, the CDC has had a lot of effort basically focusing on two facility types within healthcare settings: LTACs and ventilator-capable skilled nursing facilities. These two settings are at high risk for having cases identified within their facility, and not only that, but having transmission identified within their facility. And if you take a look at what goes on with these patients within these settings, it kind of makes sense as to how that possibly could happen. As we all know, the longer we stay basically within the longer the amount of time that we have with healthcare settings, the higher the risk that we are in basically developing infections, okay? And with LTACs and VSNFs, the time that you spend in those facilities is a lot longer than any acute care setting, period. And in addition to that, the severity of illness, chronic illness, or like a recently developed illness is more acute in the LTACs and VSNFs than per se like the long-term care facilities or skilled nursing facilities, which kind of makes sense that those settings would have the majority of the cases. As far as our response activities, during those 2 years, we had conducted 88-point prevalency surveys. The majority of them were located between acute care hospitals and long-term acute care hospitals. That's the majority of the settings where those were conducted at. We did issue 2 healthcare or health alert notifications. Both of them were back in 2021 related to this. We did have, throughout all of this ongoing outbreak of Candida auris across the state, we have demonstrated or identified facility-to-facility transmission. And as I had previously mentioned, we did have our first case of resistance noted to 2 classes of antifungals, to be specific, triazole class, and also amphotericin B. We have, very fortunate to be able to tell you, not seen 3 different classes of resistance to antifungals basically identified. I will circle back to that though, but keep it on your radar that that has been seen in this country, and I'll come back to that here in just a second. So, as I mentioned, one of the things that we are really pushing, and the CDC is also basically encouraging, is for facilities to screen for Candida auris. And it's like, okay, where do we screen, and which patients do we screen? Because it'd be very difficult to pretty much screen every single person. Plus, you also wouldn't get a good return for your efforts if you're basically doing it, because a lot of those folks may not necessarily be at high risk for this particular organism. Who we do recommend is for patients who present from long-term acute care facilities, skilled nursing facilities, rehab facilities, who within the past 12 months have had a history of previously identified MDROs, who have a history of mechanical ventilation or a tracheostomy, or have chronic or unhealing wounds. In addition to that, please basically consider patients who have been hospitalized outside of the United States within the preceding 12 months. We also are encouraging folks basically to consider screening residents of Southern or Central Indiana or Southern Ohio who have had extended stays in healthcare facilities, both acute and long-term care, due to recent incidents of acute or of Candida auris, basically identification in those areas. Also, if you go to the CDC Candida auris webpage, they do happen to have a map of states and their incidence levels. I did not include that in this particular presentation because, as you can imagine, it changes so rapidly. It would already be outdated as soon as I pretty much put it into the slide deck, and so I didn't want to waste your time. But if you do go to that page, you will note that there are certain states who have had a number of cases identified. If you receive a patient who resides within those states where they have historically had a high incidence of Candida auris, please consider those, especially if they've had extended stays within healthcare settings, both, yet again, acute care and long-term care facilities within that state. The web page here, basically, that is the page that will take you right to some guidance for infection control for Candida auris. I also wanted to include some additional pages that would be very valuable for you to take a look at here. Several different things, like, for instance, this is the CDC AR threats report, basically here. This is the different testing considerations. And also the one thing I wanted to point out to you down here, this MMWR. This is actually an article from, I want to say it was June of 2021. It was a report that had come out, and it was a from notes from the field article published in the MMWR for this particular issue, where there were cases identified in Washington, D.C. and also in Texas, where there was resistance shown to all 3 antifungal classes. Here's the hiccup. Those patients did not have a history of receiving therapy of antifungals prior to these cases being identified. So the scary thing is, the only thing that could indicate is the possibility of community spread of pretty much resistance to antifungals in all 3 classes of antifungals, which is kind of scary. So it's out there, be aware. When you're basically, you know, considering who to screen, who not to screen, factor that in the back of your head, that may be something that your facility may come in contact with, depending upon where you get your patients from. Okay. The other thing I wanted to mention is the fact that given all of the interconnectedness of healthcare facilities, with patient movements and basically happening between the acute care hospitals, long-term acute care facilities, skilled nursing facilities, rehab facilities, nursing homes, communication, as you can imagine, is absolutely vitally important. So much so that we basically had, during this whole period from 2021 and 2022, we had 2 communications go out basically to healthcare facilities. The first was back in March of 2022, basically, where Dr. Stack had sent out a letter to healthcare facilities to please standardize the communication between your facility and any facilities where you may be sending patients, so that we can clearly identify any sort of infection control data that would be vitally important for the receiving facility. Now, in communications that I've had with facilities, I've frequently heard at times that basically we do share all that information. But if for anybody, if you've ever basically been on the receiving end of a patient and you get that big manila packet of information, you know what I'm talking about when I'm saying it takes forever and a day to find the important information, and you might have to go for a long period of time before you actually get to the important information about their infection control history and what organisms basically of concern they have previously had identified in any sort of testing. In addition, for some of you antimicrobial stewardship folks, you also want to include, are they currently on any antibiotics? How long have they been on? How much longer do they need to stay on them? And any pending tests that are still waiting basically for results, so that the receiving facility knows to get an approximate time frame of when to reach back out if they haven't heard anything. Go, by the way, we understood that you had blah, blah, blah tests that you were basically waiting results. Have they finalized yet? That way you can find out if there's anything else that basically you need to be aware of while you're basically working and dealing with this particular resident or patient, dependent upon your setting, okay? The other form is, this kind of covers like the different important things as far as like interfacility communication, what things to basically make sure that you do happen to communicate with the receiving facility. The CDC also offered, if you wanted to go like, okay, what do we need to put on this form? This is just a template, okay? I don't want people to think that basically it has to be this particular form. We don't have anything. Just want to make sure that you have a communication tool that you're using on a standard basis that can clearly communicate the important factors for the receiving facility. This is just one example of a possible tool to use. Another example here is this happens to be a particular form that, if I'm not mistaken, we basically had worked on here within the state of Kentucky to basically, in this particular case, this was a simplified form that we had crafted within the state of Kentucky due to a response to an outbreak of carbapenem-resistant Cetobacter baumannii. This is also really good because it gives you like, what is the organism of concern? Basically, what are the antibiotics that you're on, et cetera. Oh, and here's another thing, basically, who's the person that basically had communicated this with you? You need to get the name of the person who basically, when you're receiving report, make sure you document in the chart who was the person that basically had communicated with your facility and who is receiving this information. Is really important that we basically get that information to make things as closed looped as possible, for lack of a better way of saying it. Okay. This is just an example. This particular form was developed in the state of Texas, if I'm not mistaken, directly in response to a regional outbreak of carbapenem-resistant Pseudomonas. And specifically, this was in the Lubbock, Texas area, where they had seen this massive number of cases in that particular area. Well, they crafted this particular form, which has a lot of similarities to some of the forms you've already seen. But they did an interesting thing, and not only did they basically provide this, but they also basically conducted a study to see like what was the impact of basically using this particular form. Okay, and because we don't need to fill out another form if it's not going to really have a beneficial value to you, to the patient, to the resident, to the transferring facility. If there's no benefit ultimately to the community at large, why even fill this out? So let's take a look at some of the results that basically had come from this. So I got to do another click here. There we go. Okay, so in this particular case, if you take a look at this graph here on the left, this kind of just goes over a period of time, like what is the breakdown of what basically happened as a result of implementation of this particular form. So the top solid line, the common approach, basically what that is, that's an assumption that basically facilities only applied contact precautions only basically in response to patients that were identified through routine tests within your facility. Okay, that's the first thing. So that's kind of like our baseline of number of patients over the course of years and the prevalence within the region. Now, if you go to the next line, the independent augmented efforts, what that basically means is they allowed for up to 15% of the hospitals to begin active detention, in other words, surveillance screening, and isolation of CRE colonized patients after a predetermined number of cases have been identified through routine clinical tests. So if you had a particular organism that was very prevalent within your facility, you could initiate screening for that organism if you're a part of that cohort of hospitals. And there was a drop in the number of cases once they basically did early identification of those cases. The other thing is that if you take a look at this dotted line, the coordinated augmented approach, what that is basically discussing is that was a regional effort. What happened there is that all healthcare facilities shared their CRE test results with a public health authority, which then basically used that information to strategically target prevention efforts at multiple facilities within that targeted region. By doing that, basically facilities were able to, like, based on prevalences in that region, implement way early on in this whole process transmission-based precautions basically before it spread throughout their facility. And that was the good news on that. So yet again, Early identification leads to early implementation of transmission-based precautions. I did want to highlight some of the folks that basically were helpful in like gathering some of the information for this presentation. I can't list all of the infection preventionists that basically I'd work with as far as who were extraordinarily patient with putting up with my numerous phone calls, text messages, emails, etc., basically inquiring about background information. I also want to thank multiple members of the Division of Laboratory Services, our state lab here in Kentucky. I also want to thank folks at the Wisconsin State Laboratory of Hygiene, which is our AR Lab Network regional lab up in Madison, Wisconsin. I also want to thank, there were a lot of pieces that I included in here that was courtesy of HICPAC, the Healthcare Infection Control Practices Advisory Committee. And then I also do want to mention Dr. Kevin Spicer, who works within our program. He is a medical officer with the CDC, and we've been fortunate to be able to work with him over the last number of years because of his involvement with the HAI program. And I do see that there are several comments in the chat. Let me double check and see if folks have any questions. I want to preemptively kind of answer some of them if they're out there. Oops, I don't mean to have that sitting right there. Okay. Lena, thank you very much for pulling that and sliding that over into the comments. I do appreciate that. Let me open it up. Does anybody happen to have any questions for me? A lot of material, and I know I rolled through it really fast, and I apologize, but this is you guys' lunch break.
Oh, this is perfect. It was a great overview. And Ruth, are you do you have any questions there in the chat?
Well, there's nothing in the chat, but I think, this was a very good overview. And I think that you talked about doing a number of point prevalence studies. Mm-hmm. And I know that this is always just such a challenge at healthcare facilities because oftentimes we don't know what to do with the results. We'll have somebody that you mentioned that maybe colonized, but that we find, as part of a point prevalence study. So I just wondered, some of the thoughts about how a facility might approach this, because, we're in the, in this point of full disclosure with our patients. And so somebody goes into a facility and a colonization is captured as part of a really, in essence, an outbreak investigation. What are some tips that you might have for infection preventionists that may be in that situation?
So the first thing is that you happen to have a case that's identified, whether it be through routine colonization screening that you happen to be conducting at your facility or not. One of the things I did want to point out is give a call out to us here at the state program. There's multiple folks that basically you can speak onto. I happen to be the one that's hanging on to our big database of cases that we've collected over the last 2 years of Candida auris. But there are multiple folks here basically in Frankfurt that basically can answer probably a good number of your questions in regards to this. But the big thing I would say is just give us a call first off. Earlier the better. The second thing is that if you go to the CDC webpage, obviously there's resources listed there, but the big thing is that there's some slight tweaks to some of your process, or at least confirmation that what you're doing is going to be effective against this organism. So the first thing is that early on, although I've noticed through our adventures with COVID, a lot of the disinfectants and cleaners have also listed as being effective against Candida. But previously, the typical cleaner / disinfectant that was used in healthcare facilities was not effective against Candida auris. So there had to be a slight little tweak to your process in order to use a cleaner that is effective so that you can actually kill this organism and halt transmission. So that's the big thing. Make sure that what you're using is effective. The second thing is that maintain transmission-based precautions. Now, being very generic on that because it depends upon your setting. If you're in an acute care setting, you want to implement contact precautions. If you are in a long-term setting like a skilled nursing facility, where in many cases, these folks that you're caring for, the residents of the facility, that is their home. Maintaining into perpetuity, if I'm saying that correctly, contact precautions, as we've learned through COVID, is not conducive to mental health. So one of the things back in 2019, if I'm not mistaken, the enhanced barrier precautions protocol came out from the CDC as guidance for long-term care facilities to use in their facilities, which is kind of like a compromise between standard precautions and contact precautions, understanding the nature of the dynamics going on within your facility. The name seems like it's super duper contact precautions, but it's not. It just happens to be a tweak in the process that you can allow as much freedom for that particular resident within the healthcare setting in those long-term settings, but is still trying to maintain protection for that resident or the other residents that they happen to be a neighbor of. So that would be the thing in regards to that. Now, if there were no precautions, one of the things we have to find out is that has it been transmitted to anybody else? And the sooner you find out about that, the better. And not just from oh, it's another organism you got to list in their history or something like that, or oh gosh darn it, we got to put up more signs outside their door. There's a real strong reason behind it, because once you basically are identified as being colonized with this particular organism, your risk of developing an invasive infection goes up. And as I mentioned way early on in this presentation, if you develop an invasive infection, the mortality rate for that, for a truly invasive infection, is 30 to 60%. There's some dire consequences if we don't prevent, or way early on in the whole process. So we have to intervene early to prevent that for the benefit of your patients / residents, depending upon your setting. That kind of answer the question you were asking?
Sure, and I think that there's a whole other part of that question that is, okay, well, how do you deal with patients? What is the type of information that you share? And so I think your point about making sure the public health is involved early on can help you, in a number of ways, both from the mitigation of transmission, as well as now how do I deal with patients? What information do I provide them? What is the duration of colonization? What do we know? And so forth. So, it's further supports the need to make sure that you've got that strong communication with public health. So definitely.
And the other thing I would piggyback off of that is that, I tell people all the time that I happen to have conversations with, and if anybody's been on here and has had a phone call with me, for a fact that I do say this. I am not all knowing. I am not the repository of everything there is to know about infection control in regards to Candida auris, or for the most part, any of the other ones. I have a little bit that I am able to retain inside my head. But the good news is I know where the resources are, whether it be a person that I happen to be sitting right next to, basically in our offices in Frankfurt, a phone call away, or basically a couple of web pages over, and hit enter to basically go to the resources that I can get to you to basically answer your questions. There are some really good resources out there. The patients, the residents, their families and friends are going to have some legitimate questions, and there are resources to help you be able to answer those questions and get what they need to feel comfortable with the situation that's going on. The other thing that basically we're strongly encouraging facilities to strongly consider is, if you are one of those high-risk facilities, you really need to consider ingraining into your process as a normal course of care admission screening. You really need to do that. And that's actually an easier conversation to have with your residents. You could just simply go, this is for your protection. Our goal is to provide the best care we can possibly provide to you while you are in this facility. And we want your family and friends to know that when they're here, we're doing everything we can to make sure that we do that to the best of our ability. Well, one of the things is to limit the risk that you are exposed to. And if we can identify within this facility organisms that we just need to keep an eye on and limit their transmission, then we need to do that as soon as possible. And one of the ways we do that is for folks that come in the door as a new resident or a new patient to our facility, we're going to swab just to double check and make sure that basically, there's not something coming in with you. And not only that, but we're doing the same thing to all your neighbors. We're not just picking on this one particular individual. So it's the same standard for everybody around you. That's an easier conversation to have with families and friends and the patients or residents involved than, yeah, we've got a problem going on in our facility right now. And in response to that, we have to, amp up our response to this and do some additional activities. I think early on up on the front end makes it a little bit easier conversation to have with the families and friends.
This has almost been a public service announcement for the work that we're doing the training center with Project First Line, trying to get basic infection prevention and control practices, because if we can get to that point, then then we remove the need to do a lot of these types of outbreaks. So this is a nice infomercial that you have given everybody about the importance of prevention. Dr. Ramirez, do you have any, I know we're getting to the end of our time, and do you have any questions or any?
Yeah, I have several questions.
I know you've got a lot, yes.
But from the presentation, Michael, when you mentioned for us to obtain travel history, if the person is travel international. In the case of Candida auris, is any particular country that we need to be concerned? Because I understand that this organism, I think I recall, was originally described in Japan. And the question is, I remember the times of COVID that you come from China, or is any particular country, or is just any form of travel international? I don't need to know.
So this is a perfect example, and that I may not necessarily have at my fingertips the exact answer to that question. I would suspect because of the length of time that this has basically been having been identified across the globe, it's very prevalent across the globe, and I don't think there's a particular country. Now, having said that, if somebody was to ask me that question, and you did, Dr. Ramirez, one of the things I'd just do is let me talk to my colleagues and basically confer with them. But the one thing I'd always say is please go to the CDC page. They can show you not only the countries that have identified it, but who has a high prevalence of it within their country. I cannot keep up with that on a day-to-day basis. I just don't have the bandwidth inside the skull of mine. Just talk to my colleagues, they'll tell you. But for the most current information, I would refer them onto that. But then, like I said, I could also basically pick up the phone and have a conversation with some fabulous folks that I get to work with on a daily basis.
These 107 patients that you have in Kentucky, was this data published? Do you have any report of the characteristic of the patients that we can look into, or they were still? Or probably let me ask you a specific question that I have in mind when you presented the case, because for us during this COVID-19 pandemic, we learned that all of a sudden patients with COVID-19 were at risk of fungal infections, and then we learned about Aspergillus and the mucor in India, and there was even some reports of COVID-19 and Candida auris. These 107 patients in Kentucky, have you seen, or do you know, there's any association with COVID-19 during these 107 patients, or was unrelated?
So I may have some incidental information on that based on conversations I've had with the facilities. I never specifically came out and said, hey, by the way, were these folks that were specifically being treated for COVID within your facility, have they tested positive for that? I never specifically asked that question, but I did tangentially happen to pick up on some of the information during my conversation. Especially in 2021 and the early part of 2022, one of the things I did note is that I'd have conversations with folks and said, well, this was identified in our COVID unit. I mean, that's a dead giveaway right off there. It also wouldn't surprise me because, as we know, when you get any kind of an infection, which really racks your system as a whole, you become immunocompromised and basically more susceptible to some of these pathogens who just love to basically take an opportunity to basically set up camp somewhere within a body that is immunocompromised. Patients who have, if you've got the more avenues of access to the inside of your body that you have, the higher risk that you are. So if you've got invasive devices, this is my go-to for clear transparency. I'm a former paramedic. I'm a D's, Dems, and Does kind of a guy growing up on the south side of Chicago. Okay. I'm also a former firefighter, so I got to really make it simple for me to understand it. My definition of an invasive device is if you weren't born with it and it's sticking out of you, that's an invasive device. It just makes it real simple. So trachs, ET tubes, dialysis catheters, Foley catheters, central lines, IV catheters. If you have an open wound that is taking forever to heal, essentially that's a conduit basically into the inside of your body. Absolutely. Any of those cases, or if you have multiple numbers of those, you can pretty much bet that basically you're going to be at high risk of developing Candida auris or acquiring it during the course of your stay in a healthcare facility. The other thing that's very interesting, as an aside to COVID-19, is I've heard reports that basically these folks that have been identified with Candida auris, whether it's colonization or a clinical infection, they have been identified as also having carbapenem-resistant Acinetobacter and carbapenem-resistant Pseudomonas, which kind of does make sense in that both of those organisms do like wet environments, along with Candida. Yeah. If it's warm and it's wet, these will grow in there, right? Yeah.
Well, I think that considering that we already, the idea here is to give it 25, 30 minutes presentation, then 10, 15 minutes, we're already on the time. This has been an excellent presentation, Michael. I think that's a lot of good information for all the members here of all the participants on our ground rounds. And then we just, Ruth, you want to close?
Sure. Thank you so much, Michael. This was great. It's, again, a reminder about the importance of infection prevention, public health partnerships, basic infection control practices, and then remembering that, that I guess we think the presence of multi-drug resistant organisms, it's going to be a problem worldwide. So this is very much a shared problem, another shared problem. So thank you for taking this time, giving us that update. And I always say I look forward to seeing you back, but that means that we probably have an outbreak or some kind of a problem. So yeah, well, we need to have you back when you have the opportunity to say, no, things are okay at this point. But from a public health perspective, that just doesn't happen. So
right.
All right. Thank you all very much. And we will again have this recording. So Michael, if it's something that you want to share this recording with others, you can point them back to the YouTube channel. And so anyone, we can share the information that you've been so gracious to share with us today. So we thank you, and we will see everyone back next Wednesday for the next Wednesday's grand rounds. Thanks very much.